Usefulness of lung ultrasound in COVID-19, a primary care experience. Hello, my name is Antonio Calvo, and I'm a family doctor at Galapagar Primary Care Center in Madrid region, at Spain. I'm a residence mentor, and I'm a membership of the Ultrasound Working Groups of the Madrid and Spanish Societies of Family and Community Medicine. My special interest is point-of-care ultrasound in primary care. In this presentation, we're going to show our experience using lung ultrasound as a diagnostic tool approaching to COVID-19 patients during the first wave of the pandemic in the months of March and April 2020, always at primary care settings. In addition, we will do a detailed review of the research that we have carried out with these kinds of patients.
My name is Javier Rodriguez-Contreras, Pediatrician also at Galapagar Primary Care Center. I am a Collaborator member of the Ultrasound Working Group of the Spanish Association of Primary Care Pediatrics, and one of the authors of this research about lung ultrasound use for suspected COVID-19 in primary care that we are about to show you.
Hello, my name is Rafael Alonso Roca. I'm a member of the working groups on Ultrasound of Madrid and Spanish Societies of Family and Community Medicine, and residency mentor. I work in the Báltico Primary Care Health Center, located in the district of Hortaleza in Madrid, which is a large center that serves 65,000 people.
Hello, we are Pino Calderín and Nieves Rodriguez. We are family doctors at Ciudades Primary Care Center in Getafe, also in Madrid region. We are residents, mentors, and we both are members of the Ultrasound Working Group of the Madrid Society of Family and Community Medicine and Pocus Enthusiastic. We work in primary care of the Madrid Health Service. Our care is organized in health centers. Patient attention is usually performed by family physicians and pediatricians. Primary care is the first point of contact to people about health problems. People usually know their doctor and have a relationship based on trust and come to him for asking for help. In Madrid, primary care is organized to offer people free access from 8 a.m. to 9 p.m. This work was carried out in the region of Madrid, one of the most affected by the first wave of COVID-19 in Spain. When the first wave of the pandemic arrived, our system was overwhelmed with patients with suspected SARS-CoV-2 infection. The hospital system suffered an occupation crash, both in patient beds and in intensive care units. In this difficult situation, primary care had to become a retaining wall against the pandemic. It had to take on multiple tasks related to the care of the majority of the population, such as clinical diagnosis, severity screening and follow-up, as well as home care service. But this should be done trying to reduce the transmission of the disease and avoiding infections among health workers who are very affected by the disease in Spain due to the shortage of the protection equipment. Furthermore, there was no possibility of performing a PCR test in primary care. So, primary care needed a major reorganization with adaptation of resources. During the pandemic, a triage gateway point was established to properly classify the patients attended with respiratory symptoms or suspected COVID-19 in order to be treated in a specific area. Despite shortage of all health care workers who treated COVID-19 patients wore PPE. The separation of the two COVID and non-COVID circuits was one of the most visible changes in primary care centers.
To limit the movement of patients, all of them with first mild symptoms were attended by telephone. Follow-up was also done by phone during the following days, and if alarm symptoms appeared or the symptoms lasted more than 7 days, patients have an in-person consultation with personnel wearing a personal protective equipment. If the patient required face-to-face care, either after telephone attention by a health worker or because he came spontaneously to the center, we followed a protocol of care and referral to the hospital. This protocol created us some uncertainty, especially when the patient presented with shortness of breath or oxygen saturation was between 95% and 92%. We routinely perform lung ultrasound in patients with community-acquired pneumonia and began to perform lung ultrasound in these patients. We began to read different scientific papers by Chinese and Italian authors that described the different findings observed in these patients, which, although non-specific to COVID-19, are highly suggestive in the pandemic context of presenting it. A wide variety of ultrasound findings was described. The involvement was bilateral. There were patchy areas with the white lung sign, areas with separated or coalescent B lines alternating with A lines areas. The pleural line can be disrupted or irregular and be normal. The sliding is usually preserved. Small subpleural consolidations may be observed with the white lung below them. Higher sensitivity of lung ultrasound than chest X-ray has been reported for lung diseases with a peripheral distribution. Lung ultrasound must be able to identify lung lesions before the development of hypoxemia in COVID-19, and its usefulness in symptomatic patients in primary care was suggested by Italian authors. The most of primary care centers at Madrid have an ultrasound device. Furthermore, a lung ultrasound examination is easy and quick to perform. It may take a few minutes when performed by an experienced sonographer, and just brief training is required to achieve the basic ability. These reasons make us consider lung ultrasound performed by primary care physicians as an optimal tool that might help them decide whether to refer patients with suspected SARS-CoV-2 infection to the hospital. Every professional who attends a patient with suspected COVID-19 must wear personal protective equipment. We protect our ultrasound machine with cling film, and at the end of the workday we disinfect it with a soap solution recommended by the manufacturer. In the same way, we use a protective cover for the probe, which is removed and replaced for each new patient. When we use portable ultrasound machines, we also cover them with disposable protective covers. In the image of the slide, we perform the ultrasound at the patient's home. In our usual practice, we perform lung ultrasound with the patient in a sitting position, the arms leaning forward on a chair or a stretcher, and the examiner located behind the patient. We place the probe pointing upwards, scanning all posterior, lateral, and anterior areas of each hemithorax, like a lawnmower, avoiding face-to-face with the patient in order to minimize spreading.
I usually perform ultrasound at my office with my Butterfly IQ device. The days I was assigned to work at COVID-19 specific area, I performed lung ultrasound to patients. I protected the probe and the tablet, covering it with cling film, as we can watch in the video clip. When first wave arrived, I was the only one doctor in my team trained in lung ultrasound. The days I was assigned to work at COVID-19 specific area, I usually perform lung ultrasound to all of patients who required it. You can watch in the video clip how I performed a lung ultrasound examination to a mild condition COVID-19 patient attended at primary care office. Observe how the patient stays in a sitting position and we access from his back. Finishing the first wave of the pandemic, some of my colleagues learned the basics of lung ultrasound examination, and the center's ultrasound machine was prepared for using it in COVID-19 patients. From the beginning of second wave, this device is used every day. The three primary care centers participating in our study are located in three different areas of the Community of Madrid: to the northwest, Galapagar, south, Getafe, and in the city of Madrid, Hortaleza, with different socioeconomic status.
The main aim of this study was to assess whether lung ultrasound findings in patients with suspected COVID-19 attended at a primary care center without access to urgent chest X-ray or blood tests in the same center to help physicians make better decisions about hospital referral. Secondary objectives were to describe clinical lung ultrasound and chest X-ray findings of a series of individuals with suspected COVID-19 who required face-to-face care by primary care physicians, and to study the association of lung ultrasound findings obtained by primary care physicians with chest X-ray findings obtained at a hospital. To our knowledge, this was the first study developed in primary care that assessed the lung ultrasound usefulness in patients with suspected COVID-19. This study included 61 patients with a clinical suspicion of COVID-19 who required face-to-face care in three primary care centers in Madrid, Spanish region, with a high incidence of SARS-CoV-2 infection between March 15 and April 15, 2020, in the current pandemic context. Patients were included if there was a clinical suspicion of COVID-19. Patients were excluded if they had mild signs and symptoms in a triage before the face-to-face evaluation, not in person. If they had a severe clinical condition after the face-to-face evaluation that ensured the need for hospital referral, lung ultrasound examination was not performed, and if lung ultrasound findings were normal and the conclusion of the physician after the face-to-face clinical evaluation was a good clinical condition, they were not referred to the hospital. The study included selected patients with moderate signs and symptoms who attended primary care in person and underwent a lung ultrasound examination, and were then referred to the hospital for further tests, chest X-ray or blood test, and consideration for hospital admission or specific treatment not available at primary care. Clinical and ultrasound evaluations of patients were conducted by 4 family physicians and a primary care pediatrician with lung ultrasound experience over the last 5 years. Each physician, wearing personal protective equipment, attended patients in a specific area designated for those with symptoms suggestive of COVID-19. The ultrasound scanning technique followed the usual procedure for performing lung ultrasound examinations. Clinical and lung ultrasound data were collected prospectively by each physician. Data on chest X-ray and management in the emergency department were collected 1 day later from the hospital's electronic medical record. Data were recorded anonymously. Variables and outcomes. The main analyzed variable was a lung ultrasound severity scale, self-designed and based on others currently published but simplified. 3 degrees of lung ultrasound severity were proposed. Grade 0, normal. Grade 1, multiple separated B lines, pleural irregularity, or both. And grade 2, coalescent B lines, consolidation, pleural effusion, or a combination thereof. The main outcome was a dichotomous variable that determined whether the hospital referral was appropriate depending on whether treatment of the patient after going to the emergency department was different from that of the non-referred patients. It distinguished between 2 kinds of patients. One, appropriate referral, consisting of patients who benefit from hospital referral because they were admitted or discharged with a specific treatment, such as hydroxychloroquine or antivirals. In our setting, these drugs cannot be prescribed at primary care centers. And 2, discharged without a specific treatment, consisting of patients who did not benefit from hospital referral. Among secondary study variables, we use a simple chest X-ray severity scale, also self-designed.
Starting with the results, we show here the clinical characteristics of the studied cohort of 61 patients. The proportion of males and females was almost the same. The mean age was 52.9 years. The median of symptoms duration was 7 days. The most present symptom was fever, followed by cough and dyspnea. No patients had severe clinical symptoms such as hypotension, low consciousness, or poor oral intake, as those were clinical criteria for direct hospital referral and not inclusion in the study. Most patients had normal auscultation, and the most pathological auscultatory finding was the presence of crackles. No patients had an oxygen saturation lower than 92%, and the majority had more than 95%. Most patients had pathological lung ultrasound findings. The most frequent pathological finding was the presence of coalescent B lines, followed by multiple separated B lines, consolidation, and irregularity of pleural line. Most patients had pathological findings in both hemithorax. So, as the presence of coalescent B lines or any consolidation defined the grade 2 of the self-designed lung ultrasound severity scale, this grade 2 was far the most frequent among our cohort. Talking about chest X-ray findings, we observed a more regular distribution of the patients among the 3 grades of the severity scale used. Anyway, both lung ultrasound and chest X-ray severity scales were found to be statistically associated. The higher the grade of ultrasound involvement, the higher the grade of radiologic involvement. As occurred with ultrasound results, pathological X-ray findings were mostly bilateral. After the emergency department care, each patient could have been discharged without any specific treatment, discharged with a specific treatment that could not have been prescribed in primary care in our setting, or could have been admitted. We considered an appropriate referral if the patient was admitted or discharged with a specific treatment, and this, considered the main outcome of the research, happened in 77.2% of the studied patients. The principal aim of the study was to assess whether the proposed lung ultrasound severity scale was associated with a higher probability of an appropriate referral. Statistical analysis showed that both variables were clearly associated. The higher the scale, the higher the percentage of adequate referrals. There was good differentiation among the three categories of the lung ultrasound scale, with significant differences between them. Looking for confounding factors, the study of the association of clinical variables with the main outcome of appropriate referral showed its association with only the presence of pathologic auscultation and peripheral oxygen saturation, but the strength of the association was less powerful for auscultation with an odds ratio of 3.8 and for oxygen saturation with an odds ratio of 5.4 than for pathologic lung ultrasound findings with odds ratio of 13.3. Furthermore, more than half of patients with oxygen saturation greater than 95% were actually appropriately referred, and there were 5 admissions among them, whereas no hospitalizations occurred in those with normal lung ultrasound findings. Only a single patient with pathologic auscultation, wheezing only, had normal lung ultrasound findings and also had normal chest X-ray findings. Individually, the presence of coalescent B-lines was the only lung ultrasound finding significantly associated with the appropriate referral outcome, as 81.8% of patients with coalescent B-lines were appropriately referred compared to 50% of patients without coalescent B-lines. The presence of coalescent B-lines was also independently associated with a higher rate of hospital admissions, with a higher grade of the chest X-ray severity scale, as well as a higher probability of having consolidations or bilateral damage in chest X-ray. Here, we evaluated the usefulness of lung ultrasound examinations performed by primary care physicians while SARS-CoV-2 pandemic peaked in Madrid, Spain. The study population was selected, and lung ultrasound was only performed when doubts arose about whether to refer the patient to the hospital. There are a small number of studies on lung ultrasound in primary care, and specifically in COVID-19. We created a simple lung ultrasound severity scale based on lung ultrasound findings described in 2020 literature, which is easy to apply for primary care physicians, and the result of which is linked to the main outcome of appropriate referral. The patients were non-clinically severe COVID-19 attending a primary care center. In this kind of patients, the presence of grade 2 lung ultrasound abnormalities suggests the need for a hospital referral, with 81.4% of appropriate referrals in this kind of patients, whereas normal lung ultrasound findings allow the avoidance of referral with enough safety, as only one patient with normal lung ultrasound findings received specific medical treatment and none of them was admitted. When grade 1 findings are showed, the uncertainty is greater, although as referral was also appropriate in 41.7% of patients, we suggest considering hospital referral or at least performing further studies as a chest X-ray examination, blood tests if easily accessible, until more evidence is available, being able to individualize the decision based on clinical data. Some studies in a hospital setting have proposed lung ultrasound as a tool that would allow for the distinction between low-risk patients, those with negative lung ultrasound findings, and high-risk patients, those with positive lung ultrasound findings. suggesting its usefulness in primary care for acute cases. Our results could support this suggestion. We found a clearly significant association between the lung ultrasound severity scale and the chest X-ray severity scale. Even so, the correspondence was not absolute, and up to 32.7% of patients with grade 1 or 2 lung ultrasound findings had normal chest X-ray findings. These results agree with other studies. Lung ultrasound can identify changes in the physical state of superficial lung tissue, which correlate with histopathologic findings and can be identified on computed tomography, but remain hidden in a large percentage of chest X-ray examination. Chest X-ray has lower sensitivity compared to computed tomography, but lung ultrasound has good sensitivity and agreement with computed tomography. Pathological lung ultrasound findings with normal chest X-ray findings could be explained by the better sensitivity for lung ultrasound than chest X-ray. Our results suggest the special relevance of coalescent B-lines as an independent finding, as they were strongly linked to an appropriate referral, a higher frequency of admission, higher chest X-ray severity, and specific chest X-ray findings. This lung ultrasound finding is named light beam or white lung, but it is not specific to COVID-19. The abnormal lung auscultation was associated with the appropriate referral, but the presence of lung ultrasound abnormalities had a clearly stronger association with this outcome. Furthermore, all patients with altered auscultation, except one with wheezing, had abnormal lung ultrasound findings. Lung ultrasound has recently been proposed as the first tool to rule out the presence of lung damage, avoiding auscultation on suspicion of COVID-19 because of the risk of touching the face and ears using the stethoscope and so avoiding spreading. We considered that these results are applicable and support using lung ultrasound in the primary care setting for assessment of patients with suspected SARS-CoV-2 infection who have a mild to moderate clinical picture. Lung ultrasound examinations are easy to learn and perform. The possibility of extending lung ultrasound among primary care physicians is feasible, as long as there is an ultrasound device in the center, which is common at least in our setting. Expanding the use of handheld devices will favor its application, even in patients' home, also minimizing the virus spreading risk, as they would probably be used only by a single physician. We suggest that it could possibly also be useful for patients' follow-up after hospital discharge and for those who did not require admission. This could allow safer hospital discharges if follow-up with an imaging test is short for outpatients. Limitations of this study included the small number of cases, and that could imply limitations to extrapolating the conclusions. We can't perform chest X-ray examinations and urgent blood tests in our own primary care centers, so it could be difficult to extrapolate these results to other settings in which these diagnostic tools are easily accessible. However, COVID-19 is a recently emerging disease, and this study provides substantial applicable results for its management in primary care, even in different primary care settings, where the results can guide decisions about performing further diagnostic studies. We include patients with suspected COVID-19, but confirmatory microbiological tests were not performed on some of them, because, as we said at the beginning, at that time of the pandemic, they were not available in primary care. Nevertheless, we analyzed patients with suspected COVID-19, not clinical treatment of patients with confirmed infection. We only studied patients referred to the hospital, as they were the only ones in which our main outcome variable could be evaluated. Therefore, we lacked chest X-ray data and information of the potential hospital treatment of patients with normal lung ultrasound findings and a milder clinical picture. Future studies will be needed for a better understanding of that kind of clinical course. In conclusion, we think this study provides evidence that supports the use of lung ultrasound by primary care physicians as a tool to assess patients with suspected SARS-CoV-2 infection. Its use can reduce uncertainty during treatment of patients with mild to moderate symptoms, helping in early detection of lung involvement, so making better hospital referrals and making it possible to avoid referring patients with a low likelihood of benefit and therefore reducing pressure at hospital emergency services. Lung ultrasound could help primary care doctors to make better decisions.
Prior to finish, we would like to show you some clinical cases of patients included in the study to better illustrate the use of lung ultrasound in suspected COVID-19 patients in primary care. Our beginning. The 20th of March, COVID arrived to Spain. A 72-year-old woman presented low-grade fever that had a 3 to 4 days evolution. She also had diarrhea, weakness, and no dysphonia. The physical exploration showed us saturation of 93% and bibasal crackles. It was a very important case given though she was an investigator's relative. We perform lung US in detect increase of B lines, confluent in right pulmonary base and subpleural consolidation. These are images of the same base with some more intercostal space where we see the appearance of confluent B lines. In the left pulmonary vertex, we detected patched pattern, which is associated with confluent B lines. And B lines in the left base pulmonary. With all these findings in the pulmonary ultrasound, we conclude that the patient has bilateral pulmonary produced to COVID. The patient is referred to the hospital where they perform an X-ray, which was surprisingly normal, but given our ultrasound findings, the treatment prescribed in the hospital was started. Our patient treatment. The patient worsened around 7 days that made her go to the hospital where they confirmed bilateral X-ray patched infiltration. They maintained treatment for up to 10 days with what gradually improves the patient being currently symptomatic. This leads us to think that radiological manifestations appear after an ultrasound. This case moved to us continue researching with the hope that lung ultrasound could drastically improve our management for COVID.
In this second case, we talk about a 40-year-old man reporting fever, mild cough without dyspnea for 6 days. The physical exam showed an oxygen saturation 96% and lung auscultations with crackles in right base. Lung ultrasound showed subpleural consolidations and thick B lines in area 6, right posterior inferior. Chest X-ray showed bilateral consolidations, prevailing on the right side. The patient was referred to hospital. The analytics showed PO2 64, C-reactive protein 15.7, LDH 489, D-dimer 738, lymphopenia. Our patient was admitted and treated with oxygen therapy, azithromycin, hydroxychloroquine, and lopinavir-ritonavir. The progress was favorable and he was discharged after 7 days. So, in this patient, we observed good correlation between X-ray and ultrasound. This third case shows a patient with underlying pulmonary pathology, a Sauer-James syndrome with hypoplasia of the left lung. She's a 60-year-old woman who reported cough, headache, and ageusia last 7 days. So we decided to make an appointment for a face-to-face visit the same day of phone consultation. Physical exam reveals oxygen saturation 96%, heart rate 110. Lung auscultation showed left base hypoventilation. Lung ultrasound showed thick B lines on the lower left fields, 10 and 12 areas, but there is a greater presence of them on the right hemithorax, 2, 3, 4, and 6 areas. Here you can watch the clip performed at 3 area, lateral superior of right hemithorax. This clip shows us the 5 area, right posterior superior. We decided to refer her to hospital because theoretically there had been no previous alterations in the right lung, and probably, in our opinion, could be caused by lung involvement of SARS-CoV-2. We don't have the radiograph performed at that time due to a technical problem in the hospital's image database, but the radiologist report refers, in addition to the findings in the left hemithorax due to its underlying pathology, a predominantly right vessel peripheral parenchymal opacity. However, the emergency department doctor decided that the findings were due to his chronic pathology and were discharged at home. 5 days later, the patient's clinical condition worsened, and she returns to the hospital with greater dyspnea, no fever, and saturation 92%. Another chest X-ray was performed. There were an increase in the number and degree of consolidation of lung parenchymal opacities in the right hemithorax. In hospital admission, PO2 48, C-reactive protein 57.5, D-dimer 811, LDH 294, and test PCR SARS-CoV-2 positive. Discharged after 7 days, treatment with oxygen therapy, azithromycin, and hydroxychloroquine. Lopinavir-ritonavir was suspended due to diarrhea, with good evolution without sequels and follow-up by pneumologist. We can draw some conclusions from this case. First, COVID-19 lung ultrasound alterations are non-specific, so in patients with underlying pathology, it can be difficult to differentiate acute from chronic pathology. Lung ultrasound could be helpful in that regard. This case shows us how the ultrasound findings in the healthy lung in the COVID pandemic environment suggested pulmonary involvement by SARS. Unfortunately, there is still little knowledge about lung ultrasound in the emergency room of our hospitals.
But currently, several months after the first wave, some changes have happened. Evidence doesn't support any more specific treatments in initial or mild stages of the disease, like hydroxychloroquine or antivirals such as lopinavir, that were only prescribed from hospitals in our setting. We now see most patients at an initial stage because we can perform PCR and antigen tests in primary care. The criteria for hospital referrals should not be based just in clinical signs, low oxygen saturation, prolonged fever, dyspnea, but also lung involvement, such as coalescent B lines or white lung, consolidation errors, or bilateral findings. And finally, as take-home messages, we could say that lung ultrasound, after data of our research, turned on a likely useful diagnostic tool with enough sensitivity to rule out lung damage in COVID-19 patients for doctors working at primary care. According to international literature, lung ultrasound findings in COVID-19 patients are easy to be identified. Further, the technique is easy to learn and easy to perform. In fact, having an imaging test in the health center capable of ruling out lung damage in this kind of patients could reduce the work of physicians for uncertainty. We believe lung ultrasound can help physicians make better decisions for patients. Thank you very much for your attention. Muchas gracias.